el nombre de su organización y también alguna canción que estén escuchando que les dé felicidad.
And then another quick thing, so you're going to be seeing two screens. I am Mega, and I'm going to be sharing the English version. And then Kate is going to be sharing the Spanish PowerPoint. So if you want to go to the view options and then just click either Mega, and I'm going to be sharing the English version, and then Kate is going to be sharing the Spanish version. So and let us know if you're having a hard time.
Bueno, y también para informarles que la presentación va a estar disponible también en español y en inglés. Y para esto pueden seleccionar en la opción Ver opciones, la pantalla de Mega Remote, si quieren ver la presentación en inglés, y la pantalla de Kate para ver la presentación en español. De nuevo lo encontrará debajo de Ver opciones.
Okay, I think people are saying the chat is disabled. Not sure.
Could be fixed now.
Okay, thanks, Kate. Should be working now. All right, so we'll get started. Again, thank you so much, everyone, for joining us here for the webinar, Health Justice in Practice, Supporting Survivors of Intimate Partner Violence and Exploitation who are living with HIV. This webinar will be recorded and we'll be sharing that afterwards. And with that, I'm going to pass it to Andrea.
Okay. Thank you, Mega. Así que bienvenidos a todos por unirse a este webinario de justicia de la salud en la práctica, el apoyo a sobrevivientes de explotación y violencia de pareja íntima que viven con VIH. También se va a estar grabando este webinario y ahora quiero proporcionarles instrucciones en inglés y en español para que sepan cómo acceder a la interpretación a través de Zoom. So, hi everyone, my name is Andrea. I'm here with my co-interpreter Annabelle, and I want to let you know how to access language interpretation. For this, you will need to have the Zoom app installed. Chromebook computers do not support this function. Please bear with us. This is our commitment to language justice. And first, I would like to acknowledge all the languages represented here today in this session. There will be ASL interpretation, Spanish, and well, language justice means that we ensure everyone can participate in the conversation more equally by speaking and listening in their preferred language. So this includes you as an English speaking audience. So just follow along my instructions so that you can select English as your preferred language. The interpretation function is already on. So when you select English, you can hear the interpreter's rendition if somebody asks a question in a language other than yours. So in your computer at this time, you should be able to see a globe icon at the bottom of the screen that says interpretation. Please click there and then select English as your language. Do not mute original audio so that you can hear everything happening in the main room. If you're using a tablet or a phone, tap gently on the screen to bring up the 3-dot menu that says More, then select Language Interpretation, and then select English, and activate the selection by tapping on Done. Okay, so you should have selected a language channel by now, and let's go on to the next screen or slide. And now I'm going to provide the same instructions in Spanish. Así que, hola a todos, yo soy Andrea. Estoy aquí con mi cointérprete Anabel. Quiero informarles cómo acceder a la interpretación de idiomas. Para esto tendrá que tener la aplicación de Zoom instalada. Las computadoras Chromebook no admiten esta función. Tampoco si llama por teléfono. Bueno, En este momento, usted puede ver en la parte inferior de su pantalla una opción de icono de globo terráqueo que dice interpretación de idiomas. Por favor, seleccione aquí, después seleccione español como se muestra en la pantalla. Y si solamente desea escuchar al intérprete, usted puede silenciar el audio original. Si está en una tableta o un dispositivo inteligente, toque ligeramente la pantalla para ver el menú de 3 puntos que dice More o Más, y entonces seleccione de nuevo ahí Español, y después, para activar la selección, termine con Listo o Done. Muy bien. Entonces ahora ya todos deben de estar en en un canal de idiomas. Esto lo hacemos por parte de estar trabajando bajo la justicia lingüística, en donde se hace todo lo posible para que las personas puedan escuchar y expresarse en su idioma de preferencia. Muy bien, si tiene algún problema accediendo a la interpretación, nos lo puede hacer saber en el chat, y una de nosotras le ayudará. Ok, muchas gracias y le paso de vuelta entonces la palabra a Mega. Ok, back to you, Mega.
Thank you, Andrea, so much for that. Again, we're so grateful that you all are here, and we're really excited to be having this conversation with our wonderful panelists. So before we get started and jump into our content, we just want to take a moment to really ground ourselves. So wherever you're seated, just make sure that your feet are touching the ground, and just, we can all take collective breath together. So just take a deep breath in, hold, and let's let it all out. Let's do that one more time. Take a deep breath in, hold, and let it all out. Thank you so much again, everyone, for doing that with me. That usually always helps me to center myself and ground myself before we get started with our content. So just kind of want to give a quick introduction to who we are. We are Health Partners in IPV and Exploitation, which is a project led by Futures Without Violence and funded by HRSA BIPIC, a Bureau of Primary Health Centers, to work with primary community health centers to support those who are at risk of experiencing or surviving intimate partner violence, human trafficking, or exploitation, and to really look at the prevention efforts and to focus on prevention aspect of that. We are part of 21 other NTAPs, which is National Training and Technical Assisted Partners, part of BIPIC, and we actually offer health center staff as well as domestic violence advocates ongoing educational programs such as learning collaborative on various topics. So in the past, we've done learning collaborative on maternal health, health equity, and cues intervention. We also do webinars like today's, and really develop clinical and patient tools and resources, toolkits, evaluation, and health IT tools for health centers to use. And you can learn more about the work that we've done, some of our other resources on Health Partners and IPV and exploitation.org. I know Kate's going to be sharing that on the chat. So this is the team and the staff that has been working on this webinar. We have our panelists at the top, Nishi Parkinson, Ashley Sly, Dr. LaShonda Spencer, and you're going to be hearing from them later today. So I just wanted to do a brief introduction. We have our moderator and facilitator, Surabhi, myself, Mega, I use she, her pronoun, and then we have Kate, she, her, they, them, who's going to be helping us, and you'll be seeing Kate put stuff in the chat and just helping us with the tech. So this is our learning objectives for today. We want to strengthen participants' understanding of intersecting barriers to health access for survivors of violence who are living with HIV. We want to identify 2 ways to promote health and well-being of survivors in clinical settings. And lastly, we want to engage in partnership building with supportive community-based services. And this is our agenda for today, intersection of IPV and HIV. Then we're going to move on to talking and having a panel discussion on approaches to promote the health and well-being of survivors living with HIV. And then lastly, we're going to be sharing some tools and resources to support the work that you all are doing. So we really want to get started with having this conversation with really with the health equity lens. So this is the definition that we're going to be kind of using in order to have the health equity framework. We are defining health equity as individuals and communities having equitable access to the things that they need for their well-being and self-determination, such as no one's health outcome are as the result of interpersonal or structural oppression. And we believe that health equity approach really requires us to center the historical marginalized, exploited, and oppressed communities, and to really focus not on the individual behavioral change, but to really look at some of the structural and systemic change that's needed. So again, this is going to be really our focus on this conversation that we're going to be having today. So now we want to talk a little bit about what IPV, intimate partner violence, is. So intimate partner violence, as many of you know, is defined as a pattern of behavior that a person uses to gain power and control. Again, the key is power and control here over another person that they are in a relationship with. And oftentimes when we hear about intimate partner violence, we're only thinking and hearing about physical violence. But again, IPV can mean a lot of different things. It can mean emotional and verbal abuse, coercive control, sexual violence and coercion, reproductive coercion, psychological abuse, as well as financial abuse. And IPV is very, very common. So between 1 in 2 and 2 in 5 people in the US have experienced rape, physical violence, and or stalking by an intimate partner in their lifetime. And because of various intersecting forms of sexism, racism, trans homophobia, and other forms of oppression, marginalized and or historically exploited people experience IPV at a higher rate. Again, IPV happens in a monogamous relationship, non-monogamous relationship. Again, it's very common, happens within various race, class, gender, but that intersection forms really, really does create barriers for our folks who are experiencing IPV. So like I said, oppression and systemic violence really does create disparities for folks experiencing IPV. 41% of Black women have experienced physical violence by an intimate partner during their lifetime, compared to 31% of white women, and 30% of Hispanic women, and 15% of Asian or Pacific Islander women. Compared to cisgender transgender individuals are 2.2 times more likely to experience physical intimate partner violence. And again, poverty, economic insecurities are some of the barriers for survivors who are seeking safety. And also to acknowledge that people with disabilities are significantly more likely to experience all forms of intimate partner violence. And with that, I am going to pass it to Surabhi to talk to us a little bit about the IPV and HIV and talking about the binary with intimate partner violence.
Thank you, Mega. I'll just wait for you to pin me. And in the meantime, I thank you so much for all being here. My name is Surabhi Kuke, and I work with the Futures Health team, as Mega mentioned. So I want us to think a little bit about this sort of false binary between survivors and people who use violence. Sometimes we think about them as very different people in order to create a very close, protective space around the survivor to kind of distance the person who harmed them. But we have to remember that people who use harm come from the same communities as the people that they harm. And it's important to break down the binaries that divide our communities, that actually exacerbate violence in our communities. Survivors of violence are harmed also by the societal expectations of being a quote unquote perfect victim. There's no room for the gray area. There's no room for growth or making a mistake or trying something different sometimes. It is possible for survivors to use what looks like abusive behaviors and engage in behaviors that are criminalized in order to survive. So the notion of the good victim or the good survivor, it can be really harmful to survivors doing whatever they need to survive, protect their lives, their children, etc. And often when it comes to providers working within systems, survivors may be reluctant to disclose because they are afraid of judgment, increased violence at home or in their relationship, or simply not knowing what might happen if they did disclose. Now, to look at the folks in our communities that are using violence. The reality is, not unlike survivors of violence, they are very likely to have experienced or witnessed violence in their own childhood. So as children have witnessed. They may be at very different stages of their own awareness or accountability for their behavior. So there may be some that are in a state of complete defensiveness and denial. There may be others that have really moved through and with the support of therapeutic supports or community supports to begin to take accountability. You don't know this by looking at someone. And they too might be reluctant to disclose anything to a provider because there's really no incentive to being truly accountable for harm you might have caused. Unfortunately, in our society, punishment is the primary tool. So they are left having to hold their struggle alone. So if we look at ways to break down this binary, it reminds us that in healthcare systems, we have an opportunity to really expand the care we give to the community, recognizing that trauma is living in the populations we serve. And sometimes it looks like victimization, and sometimes it looks like being abusive. So this is not to excuse abuse ever, but it's to really expand the way we think about who is victimized, who is abusing, and why. Next slide, please. So as Megha mentioned, intimate partner violence, or IPV, as we call it quickly, it shows up in many different ways. Just to think more specifically about in the health setting, we know that health conditions are harder to manage when there is such a high level of stress on the mind and body. You might notice a patient is missing appointments regularly and you don't quite know why. You might notice patients hurting or controlling their partner, so using force or abuse, hurting or controlling their children, another way of being coercive or managing or coping with the struggle. There may be mental health impacts. You might notice that a patient is not able to adhere to treatment plans or care plans, something that is particularly relevant to HIV care. There may be disclosures of abuse in the clinical setting. You might notice injuries. You may begin to observe impacts on children, and further, more peripheral but equally difficult impacts on housing and economic security. The vulnerabilities caused by the rupture that intimate partner violence brings into a relationship or a household has many, many ripple effects that can be visible in the healthcare setting if we're looking. Next slide, please. So this is an incredible resource. We call it the Power and Control Wheel. It looks like a lot of you are from advocacy programs, so you are familiar with the Power and Control Wheel. For colleagues in the healthcare setting, this might be a really interesting new resource for you. This one specifically centers on the way HIV is used in power and control, in abusive patterns. You will have a PDF version of this coming to you in case this is difficult to read, but just to give you a map, the wheel highlights some of the different ways that HIV might be used to manipulate or control another person. So we've talked about emotional abuse and economic abuse, but using children, using isolation, using different forms of coercion and threats, the opportunities become endless because of the stigma associated with HIV and the fears associated with disclosure. So I encourage you to take a longer look at this. This resource is available in English, in Spanish, French, Korean, and soon will be available in Arabic if those languages are useful in your community. They're available in the toolkit by NNEDV, the National Network to End Domestic Violence, and that information will be shared with you in chat. I'll move to the next slide. So as I was just saying, HIV stigma is really one of the central kind of the fulcrum on which vulnerability really increases. One study done in an HIV primary care clinic found that nearly 3/4 of the sample, meaning people living with HIV, reported a lifetime experience or an experience of IPV in their lifetime, and 20% reported current abuse. That, if you remember, the data Mega shared about 1 in 3 on average nationally experiencing IPV in their lifetime. We're talking now 3 in 4. That is a staggering difference. More than 1/4 of those who reported being abused felt that the abuse was related to their HIV status. Again, a link between the stigma or the fears about HIV increasing vulnerability to violence. Okay, next slide. This again is another way to state how big of an issue this is. Nationally, over half of women living with HIV have experienced partner violence, which is much higher than the national prevalence among women overall. So what do we do about it? We won't be able to go into great detail about this, but we encourage you to look at the toolkits that we'll be sharing to learn more about this methodology. It's an evidence-based intervention that we call CUES. CUES is an acronym, stands for confidentiality, universal education, empowerment, and support. The method relies first on ensuring privacy, seeing patients alone, making it a policy to see patients alone, not doing a case by case. This person looks like they need to have a conversation, making it a policy. We always see patients alone. Ensuring they know the limits to confidentiality, ensuring your patient knows that there are some things that you have to report depending on where you are located. And then providing universal education. We have these beautiful little safety cards. There'll be more information about how to order these for free. These are the universal education tool. We have scripts available for you to learn from, to practice, to adapt in your own voice. But the basic idea is, because relationships can sometimes get hard, we're giving these to all our patients. Take a look at it and let me know if you'd like to talk about it. There are resources and hotline numbers on the back that might be of help to you or someone you know. The universal education removes the need for disclosure, removes the need for screening, because we know that disclosure rates are quite low in the clinical setting. So taking away disclosure from the equation frees you up as a healthcare provider to just make sure that everyone gets information about healthy relationships. And then we know that even though disclosure is not the goal, disclosures sometimes happen. So being able to provide a warm referral to a partner organization that is able to provide the support that the survivor needs is the final essential key. So partnership building is another element of what we would encourage you to grow. Next slide, please. This focus on universal education, as I mentioned, treats survivors with respect by giving them the information about relationships and where to get support without expecting anything from them first. It can be used also to normalize the act of seeking support and destigmatizing the health conditions that might be in the way. For instance, traumatic brain injury or other issues that create neurological concerns. So we encourage the universal education approach to improve the support that survivors get, and also to advance equity and kind of democratize the access to information. Okay, next slide. So now I am absolutely delighted to start an exciting panel discussion with, as we mentioned earlier, Ashley Sly of the National Network to End Domestic Violence, Nishi Parkinson, an independent consultant and activist and speaker, and Dr. LaShonda Spencer, professor of pediatrics and internal medicine at Charles Drew University. I am going to invite the three of you to come on screen. And I believe we can maybe take the slides down so that we can see our panelists better. And while we're doing that, I'm going to invite, first of all, welcome face to face. I'm going to start us off with a request for a round of introductions. If it's possible, before we begin, Mega, can you just spotlight the five of us, our ASL interpreter, myself, and the three panelists? Just to kind of clean up, like just to make a cleaner screen. Thank you so much. Mm-hmm. Okay, so just to get started, let's start with some introductions. Can I invite you, each of you, to tell us a little about yourself and how you've come to be a part of this discussion about the intersection between IPV and HIV and health equity. Why don't we start with you, Dr. Spencer? I see you right next to me.
Good morning, everyone. Hello, my name is Dr. LaShonda Spencer. I'm medical director for MLK Oasis Clinic in South Los Angeles and the director of Drew Center for HIV Research, Education, and Services at Charles Drew University. I've been working in the HIV field for the last 20 years with an emphasis on women living with HIV and the intersection with IPV and other inequities women face.
really glad to be here with you this morning. I do have to apologize in advance that I have to leave off early for another meeting, but I'm looking forward to our conversation today.
Thank you. So glad you're here with us. Nishi, can you join us and share a little about yourself and how you became part of this discussion?
Good day, everyone. My name is Nishi Parkinson, and I'm from St. Louis, Missouri. I became part of the working process of IPV and HIV. I am a 26-year living positively and strong woman living with HIV. And I'm also a survivor of intimate partner and domestic violence too, as well. Capacity building, champion, activist work that I've been doing for 26 years or longer has paved the way for me to be here today. I pay homage to Positive Women Network USA. I pay homage to Ribbon Consultants and so many others who have provided me the affordability to learn policy, how to pass bills and walk the halls of legislation to help women in their own diaspora and diversity and inclusion, to allow us to be able to speak and affirm our spaces, and also be able to build our tables so that we can make sure that we rise to our full potentials. So thanks for having me.
So glad you could be here with us, Nishi. And Ashley, can you introduce yourself? Tell us how you come to be a part of this discussion.
Of course. Hello, everyone. Good afternoon, good morning, wherever you're joining from. My name is Ashley Sly. My pronouns are she, her, and hers. I am the Deputy Director of Positively Safe at the National Network to End Domestic Violence. The Positively Safe project addresses the intersection of intimate partner violence and HIV, and we provide training and technical assistance to both domestic violence and HIV organizations at the local, state, and national level. And I've been working on this project since its inception in 2010, so almost 13 years now. And have really had the opportunity to work with some incredible advocates and women doing work in this space, including Nishi, but as well as the Positive Women's Network, Sister Love, and in Atlanta, Georgia, the AIDS Foundation of Chicago. So really amazing people, and just it's such a privilege to be able to work alongside these incredible advocates every single day.
Thank you so much. And I should add, Ashley and I host a podcast on this topic, this very intersection, which we'll share with you, called Expanding the Continuum. And I hope that you check it out and enjoy it. We'll be sharing those details with you later. So given the data that was presented earlier, I want to start with a question about what is working right now. What do you think the healthcare system is doing well, if anything, and to address these intersections? And maybe also, what kinds of improvements or changes have you seen over time? I'd love to start with your thoughts, Dr. Spencer.
So I think over the years, there's been more emphasis for screening on IPV and domestic violence, particularly over the last 10 years. Within that time, the U.S. Preventive Task Force released a recommendation for all providers to do screening for women of childbearing age for intimate partner violence, and that happened in 2013. And so that was a first start, and I think that was a really good start, because although we were supposed to be doing it, there wasn't anything that told us or gave guidelines or recommendations on how to do it. And so when the task force instituted that recommendation in 2013, then medical systems and systems of care had to develop some system to implement that screening. Having said that, there still have been persistent challenges, right? Because we're supposed to be screening all women of childbearing age, which limits who you're screening if you just limit it to the childbearing age as well. But it really didn't give any details on how to do it, and institutions had to kind of do it on their own. Now, in the HIV field, we're well aware of the literature, as you mentioned in the slide, And we're well aware that, these sort of vulnerabilities around IPV and domestic violence is what put women at risk for HIV. And so we're well versed in the literature in doing that. But I think the challenges of implementation of how do you do this in the clinic, again, without clear guidelines on how to do it, is a challenge, because a lot of times the providers, either think they don't have enough time. If they open that door to address the issue, it may take longer than necessary, or they may perceive it to take longer than to extend their visits. They may not be trained. And particularly if you have a lot of staff turnover, you have to train your staff every year or however often you have the turnover. Providers sometimes fear offending the patient. So I don't want to offend or embarrass the patient. And providers may have their own personal experiences with intimate partner violence that may interfere with them addressing the client that's in front of them. So I think the challenge, it's great that we have this recommendations, but the challenges persist in how it's implemented in each clinical setting.
Thank you. That was brought up a lot of important issues there. In your time working on these issues, have you seen any kind of shift and in any positive directions?
Well, yeah, only because I'm a biased provider. So this is something in my clinic that we do frequently. And so I think there's more emphasis and recognition that we need to, particularly in the realm of health equity, that we really need to address some of these issues. And these are systems issues. They're not, although it's affecting an individual person, this is a system issue that we really has to be attacked at the system level. And so if your agency is not addressing these issues from a systemic level, then it's really hard to make an imprint on addressing IPV and the fallout from IPV. Yeah. So I do think that there's more emphasis on it. So I do think that's a good thing. I do think clinics are striving, particularly here in the Los Angeles area where we have access to a lot of training, we have access to a lot of services like other communities do as well, but there's an intentional effort to do something about it.
Thank you. I'd love to hear from Nishi too on this. What have you seen? What do you think health systems are doing well, and what have you seen improve over time?
I can speak from an eye perspective in the work that we are doing in Missouri, that those screenings are 100% helpful to break down the barriers of stigma among women that may walk into a clinic space that need the services but feel like she is being judged. So overall, you have to make a safety plan for that woman when she enters your facility and make sure that you keep it as healthy as possible. And also you use your peer-led components that you may have in your clinic settings to help if there is a woman that has identified as a survivor in your clinic space, to utilize her expertise and her knowledge to gain momentum to talking with that young woman. We know we can't fix all of the problems right there on the first day, but to allow us to walk through a safe space with continuity and with strength and empowerment so that she can get to the first layer of getting some of her questions answered or receiving the care that she needs and getting medications and, following up with her and giving her the essentials that she may need on that day.
Thank you. You really lifted up some critical components of trauma-informed care, that peer support, that empowerment. And so I appreciate you lifting that up, because it tells us, it keeps us reaching for providing holistic trauma-informed care that really holds survivors at the center. Thank you. Thank you for those reflections. I'm going to move to another question now. And I'm going to ask you, Ashley, to start us off. How would you characterize some of the specific barriers that survivors living with HIV face when they're trying to access health and advocacy services?
Yeah, great question. Well, there's a number of things that come to mind here. If someone is having to access more medical appointments, that's obviously, there might be a barrier there, especially if they already have concerns about their safety and how they're getting to those appointments, or if their partner might be tracking them. So, having to find alternative ways of getting there and making sure they're able to remain in care. And even for those that are looking at preventative options and being able to access PrEP, the additional appointments that come with that. So from both sides, there's definitely that barrier there. And then part of the cost that might be associated with it, from medications to the doctor's appointments and blood tests, and all of those additional costs that can be compiled on top of that as well. And especially if your partner controls your finances, being able to access the funds you need, it just becomes more and more difficult. And even if you have access to some of the programs that reduce the cost, it's still maybe not enough. So all of those kind of compounding financial abuse tactics and medical abuse tactics there really create more and more barriers for survivors that are living with HIV. And then, we have to talk about access to medical information, right, through health insurance. And if your partner is controlling your health insurance, or maybe you're concerned that they cancel your health insurance. So, that is a huge issue. And then I think ultimately being unsure of who they can trust. If for so long your partner has belittled you and made you feel as if you don't know what you're talking about, and really gaslit you in every instance, you're not really sure if this medical provider is going to believe you. So that in itself is a huge barrier for folks. And that's why I think the interactions that happen with medical providers is so important. Knowing that maybe the conversation doesn't happen this first time, but maybe it happens the second appointment or the third appointment, but you've built that foundation.
Yeah. Thank you so much. I'd love to hear your reflections on that, Dr. Spencer, what you've observed or perceived.
Sure, I would echo what Ashley says. I think some of the more common things that I see is really the clients knowing that what resources there are available to them in the setting of few resources available. Right. And so trying to navigate that space, and then really getting in once they get to the spaces where the resources available, trusting the clinical and the medical system there, because that system may have failed them in the past. And I think that lack of trust, and it's up to us as providers and medical systems to really ensure that trust and make sure that we're in a welcoming environment to that woman that's presenting to us because of the experience of trauma in the past, as well as the mistrust of the medical system that I see a lot in our Black and Brown communities. And then, as Ashley mentioned, I agree with all of the points she said in terms of, do they have the resources to get to where we need to go? The transportation, the lack of housing. If you can't be stable in some of these situations, financial stability, do they have money to pay rent, or is it controlled by their abusive partner? Where's their emotional and physical support coming from as well? And don't forget the added responsibility of taking care of the kids if they have them, or if they've got a mom or a dad or someone else that they're taking care of. So I think those all play into, the barriers that we see as they're trying to assess their own care, but have to think about all of these other things in that same setting.
So, okay, so this is going to be a question for all of you. It's like magic wand time. If you could change two things, we'll start with you, Nishi, about how healthcare systems address IPV and health equity in the way that they care for survivors living with HIV, what would those two things be?
Wow, that is a lot. Because, we're still placing emphasis on the continuum of care of HIV and intimate partner domestic violence, or IPV. And we always circle back with housing and transportation. right? Those are the two major things that we know of. And we know any woman over the age of 44 may have grandchildren, may have an extended family or kinship of some sort where she has to focus to be the matriarch of that family while still walking through a critical time. So I think housing would be my wish to have for all women, and then also the transportation abilities, because we know that budgets are pressed to the full extent. You know, when we get money from federal, state, local donors, you know, it's stretched very thin. So I think we should come up with a way to make a consensus or a consensus statement to pay homage to the affordability of those two essentials that are wholeheartedly needed.
I really appreciate the way you panned it right out. Like the social determinants of health are what we have to start taking seriously as health system priorities, is what I'm hearing you say.
Absolutely.
Transportation, housing, awesome.
Absolutely.
Ashley, what are your thoughts on this one? Magic wand, two things that would be different, that could be
Yeah.
different.
I mean, I echo what Nishi talked about, and just really the importance of housing, right? Housing is healthcare. If you are not stably housed, how are you able to continue to take your medications and be able to afford those if you can't even afford rent, which we know is out of control in this country as it is. On top of that, while I think this has improved, I really do think we have to be thinking about the questions that surround IPV and making sure they're standard in all healthcare settings. And not just, are you experiencing domestic violence? Like, we know that what people understand about domestic violence or intimate partner violence really varies. So we need to be thinking about this and asking about IPV in a variety of ways, and not just focusing on physical and sexual abuse, because all of the other tactics can be just as harmful to people as the physical violence. You know, and I say this because I can count on one, maybe two hands, the number of times I've been asked in the past 10 years about experiences of IPV. And then once I tell them that I actually work in this field, then I definitely don't get asked at future appointments. And we know that advocates also can experience intimate partner violence. So ensuring this is just a standard thing, I really, really hope that we're going to get to that point. And I think that what comes with these questions is also a discussion on language. So really thinking about the language we're using with people that are accessing our services and what that language conveys. So are we using complex language that can be hard to follow? Is our language inherently biased? Does the term abuser or perpetrator cause a survivor to close off from you? And, you know, speaking of the term survivor, what is implied by the term victim or survivor? So thinking about those things. And then the last thing I will say that I would love to see is really thinking and honoring confidentiality and privacy when it comes to healthcare providers, especially those that are working in, say, primary care that may see patients that are couples. So what does that look like, and how do you kind of work through those challenges so you can still provide healthcare to people? And having an understanding of also IPV confidentiality and those laws that restrict organizations from sharing information without those written, informed, time-limited releases is really key, because just because you might be the good person doesn't mean I can just hand over the information to you. Those laws are in place for a very specific reason, because we know how critical confidentiality is to the safety of those experiencing intimate partner violence.
Thank you. Thank you. Again, a big systems approach. I really appreciate you panning out with us. So, Dr. Spencer, I'd love to hear your thoughts too. If you could change a couple of things about how healthcare systems address IPV and health equity when caring for survivors with HIV.
I have two categories.
Okay.
So you need to address the social determinants of health. So my two in that are housing, which was already mentioned for the reasons mentioned before, and the financial instability, addressing that with a guaranteed minimum income. I think that has been shown in several pilot studies to work, and it lifts people up, and particularly women with histories of IPV where they may not have control over the finances. This would be something that would really uplift those women. And then the second category is training for providers and healthcare staff. I think IPV training, intentional training, is really important, not just the US task force recommendations that no one will go to unless their institutions make them read the policy, but really intentional training. We did cues training that you mentioned before. We worked with Futures with Voices at our clinic here in Los Angeles, at both my clinics. At Los Angeles, we trained the entire staff with the cues training, and it really just was so instrumental in getting us to think about how we screen for IPV in a different way, without all of the, without feeling intrusive, without feeling that you were judging or the patient was going to be judged. Whatever the cards that Sudhabi showed are just fantastic to hand out, and we all did the training from the medical directors down to the nurses. We had champion leads in the clinic to help lead the training, and I mean, it's a wonderful intervention, so I highly recommend that. But I think clinics need to have more intentional trainings in IPV, and know that they can do it without feeling intrusive to the patient or client that they're seeing.
Thanks so much, and thanks especially for lifting up cues. I think I had the privilege to support that training, and to see the way that people sit in different places within the clinic, the different ways that they took up the information and the intervention, really was, it was just important learning that everyone has a role. It's a team-based approach. It's not just in the hands of the doc or the nurse, that there are many, many people that work in the clinical setting that have an opportunity to reflect, one, the health clinic is a safe place to talk about this, two, you can talk to us about this, like we actually have some skills, we know something. So it was really a joy to work with your team, and I'm glad that it was helpful there too. But okay, so moving along. I want to think about what I want to ask next, because, I have a lot of questions in my mind about, but I'm going to go straight thinking about survivors. What do you think, and maybe I'll ask you first, Nishi, what do you think is most important for care providers to understand about serving survivors? What do they need to know about survivors, and what they need for good quality care?
Wow, great quality of care, great bedside manners. When we walk into a facility of the uncertainty and the unknown, I can just take myself back to 1997 when I was diagnosed as a 17-year-old, and being afforded an opportunity to, have my sister and have my best friend sit by my side during that time period was meaningful for me, because I didn't know what just had happened to me. Getting a diagnosis from a young woman, and you walk into this facility and they tell you to go left, right, down the hall, turn right, sit down, write your name on this piece of paper, and the receptionist will be back with you shortly. You don't know what that means. You're just doing exactly what was given to you in detail to guide you to a location inside of a facility. But now we are 26 years forward, right? We are doing more robust continuity of steps and looking at the whole person. I think now that we're looking at the whole person, I believe providers also should do the same. Also, providers, first year, second year, third year, fourth year, I continue to say this, they have to be willing to talk to us, to be willing to allow us into their spaces for them to learn too as well. It's not all in a textbook. It is actually doing the work and actually feeling and showing up for us in specific spaces, and doing what is asked of us for them to help us. You can't help us if we continue to sit with you and say, okay, I understand. And we probably didn't understand. That woman probably didn't understand sitting there. And then she leaves feeling like she was left out. So I think the momentum is to always pull in your multi-D team to work the puzzle, because it is a puzzle, because one woman shows up one way, another woman will show up a different way. And then 2 weeks later, when she comes, or 4 weeks later for that 4-week turnaround appointment, she's looking a little different, right? She's strong in her walk, she's stronger in her talk. But what happened in that time period? Because she talked to some people behind the scenes that could help her, such as a Ashley, such as a Dr. LaShonda, such as me, so we've elevated those processes for her to be able to stand up, in her own adversities. But I think the training and the knowledge of all the toolkits that we have built from PWN, from the Q, from Ashley's team, I think that momentum should be intersected and integrated in teaching capacities for physicians, so that they can know it's just not about HIV when they walk in that door. It's just not about intimate partner domestic violence when they walk in. It could be that the hit, and I was sitting in the car and didn't think I would get hit 20 minutes before my visit.
Mm-hmm.
And then I have to walk in and suck it up to get past the registration desk. So the momentum happens from the front door, the security officer, that she may pass, knowing that this officer may say something to her that may trigger, because she's not well with talking with the authorities, and making sure that your front end staff is able to be watchful in those cues when she walks in, to help her get to a safety net. She may not want to sit in that front lobby 2 hours or 45 minutes because of the situation that just took place.
Yeah.
So hopefully physicians could do better and empower in that way, and to make sure that it is a whole person view.
Thank you.
Thank you.
Ashley, anything to add to that?
Oh yeah. I think kind of reflecting on what's been said about training for physicians, but also thinking about this dismantling the narrative around the perfect survivor. Mm-hmm. So having a full understanding of trauma, and that trauma manifests in different ways, including memory challenges and physical pain and insomnia and excessive sleep, but also anger. So, being able to understand that and I don't know, not become so defensive in those spaces, when somebody forgets their appointment, that we're not just like, well, you missed your second appointment, so you can't come back, how providers like to say those kinds of things. So really having an understanding of how trauma impacts our full bodies and our ways that we cope as well. And I think with that, you have to recognize that you have to be patient with survivors, and understanding that the experiences of intimate partner violence is individualized from person to person. So while there are common tactics of abuse, how they're used can look very different for each survivor. And I would also say that really survivors should lead. While we can offer them all sorts of resources and referrals, if they're not ready or do not want them, we should not force them to take those resources or referrals. Leaving an abusive partner is not always the goal, or at least maybe it's not the initial goal for survivors. It may just be figuring out how to keep themselves safe in certain situations, or rebuilding familial connections, or determining how to save money for the time being until they are ready to leave. The IPV may not be their biggest concern at the time, and that's okay. If you've seen the washing machine video that's on YouTube, you're very familiar with the fact that this woman only needed a washing machine, but the advocate wanted to give her everything else but the washing machine. The washing machine was the important piece that could make a difference for her. So really honor their expertise. They know their situation, they know their partner best, and what will or won't work for them in those situations.
Thank you. That was such a great snapshot of survivor-centered practice. I really appreciate you framing it out that way. You talked a little bit about not necessarily having kind of like a cookie cutter approach, like just a quick referral, like really listening to what was needed and inviting the survivor to lead. Can I invite you, some of you, to talk a little bit about how health settings can really support survivors through partnerships with local advocacy programs? Because it might not be the referral. It might simply be having the partnership that changes the way that you work. So I want to start with Dr. Spencer, because I know you're probably running out of time and have to jump out soon. So I want to make sure I grab your thoughts on this one.
Sure.
How do you see partnerships in really improving care for survivors?
For us, when we went through the CUES training, so we had some partners that we worked with around IPV and domestic violence and other housing resources for women, but going through the training helped us really formalize that process and really put it down in writing what we were going to help and with in terms of our partner and what the community partner was going to do for us and how that interchange and exchange of services was going to look like. And I think that was really important because things came up that, that our community partner says, hey, we can do this, that, and the other that we didn't know was available. Right. And the same vice versa for us. And so I think it was really important to really to set up those relationships in a formal way where you're having MOU between the agencies and you sit down and you go over exactly what we can offer between the two agencies and what that would look like, including some of our agencies, our partner agencies would come to the visits with women. And that made the woman feel much more safer and comfortable because there was someone there. We have peer navigators as well at our institution. So our navigators, vice versa, would go with the woman to the agency to help, just bridge that gap and a warm handoff and bidirectionally. So I think it was really, for us, important to really formalize that relationship, even though we had been working together for years, but really to make that a more formal process. And streamline it for our clients so that there weren't any hiccups, that we knew exactly what each agency was going to do and how they were going to help and what services were available. So I think that was really important for us to formalize partnerships that we had already, but hadn't gone through the formal process.
Yeah, and there is like a transformative impact of formalizing it because it stays on people's radar. You have you learn, there's a cross-training element. You learn about what the other agency really does and you kind of integrate it into what you have to offer. So even if the survivor is not interested in going anywhere, they will have acquired a little bit of information about what it's like to go there. What happens when you call that hotline? What do they do over there? It's not just here's a number, call if you want.
Right, exactly. The
Wonderful.
warm handoffs are really important.
Yes, the warm handoff. Any other thoughts on that, Ashley? I know that you had sort of started referring to it, but I'd love to hear if there's anything else you'd like to say about partnerships.
Yeah, I think one specific thing that could be helpful that I think Dr. Spencer touched on is even if someone is say not ready to go to a domestic violence or sexual violence program or organization, if you have that partnership built, even offering for the advocate to come to you. So the next time that the survivors do to come to your office, they don't have to think about going to another place. Again, if feel like they're being tracked, we want to cut down those barriers. So if you have that partnership in place that allows someone to be even on site once a week for survivors to access, that's a huge opportunity for them to connect without the additional location. But I think the most important thing I always like to acknowledge is when it comes to our partnerships, really thinking about how we make them meaningful and sustainable. So thinking about who's at the table when we're building these partnerships. So it shouldn't just be executive leadership, but it should be people working with survivors, working with people living with HIV, working on the ground, need to be really included in the development of those partnerships.
Mhm.
And, really thinking about creating a plan for how this partnership grows and moves. What goals are we setting for ourselves? What is our strategy here? What are our next steps? Who else is missing from this conversation? So I think that can be really helpful in creating a plan that's going to move forward. That it's not just a, yeah, we've said we had a handshake and we walked away, but then what actually happens next? So we do have a collaboration action plan people are welcome to use. It's in our Positively Safe toolkit on our website. For me, it's helpful because I like to write things down and be able to refer back to it, and everyone can have a copy of it. So you feel like you're on the same page as well.
Thank you. Yes, I really want to highlight the toolkit that they have developed in the Positively Safe program at NNEDV. I think there are many resources in the chat. You'll definitely receive links for that toolkit. Yeah, not to be missed. I feel we're coming to the end. I mean, not the end because we have lots of time for question and answer, but I would like to hear I'd like to ask one more question thank you, Dr. Spencer. I'm glad you were here. Thanks so much for joining us. Nishi, maybe you can take this question. What do you think healthcare providers, I'll start with, I know we have talked about social determinants of health. We've talked about housing, universal basic income, a variety of sort of supports that make it possible for survivors to thrive. But when we think about health equity, what do you think healthcare providers can do to promote health equity for survivors that are seeking care in HIV care settings? In addition to what we've already mentioned, if we think about the health equity frame that we opened with, that not about individual behaviors, it's about systems, right? What do you think? What kinds of systems changes do you think would benefit survivors living with HIV?
I think some of the system changes should be developed or implemented at the ER level. Because you have social workers that work in the ER, you have physicians that work in the ER, and they see this daily. 9 times out of the 10, a friend may bring them, or the individual may be brought in by EMS, right? So I think that level of care plan for a young woman who may be coming in, and this may be her first time experiencing something like this. So it's real fragile, it's real new. We're not sure if she's going to go back. Like Ashley said, she has to take the lead, right? And that lead may look different. So I think that training efforts at the ER level should be implemented worldwide, not just state by state or jurisdiction by jurisdiction. I think it should be worldwide that we should implement some of the tools that we've learned what work well for certain situations to improve the continuity at that level. I do believe that our organizations have done a great work ethics to pull or overlap intersection of organizations and consortiums. But I think also we need to hone in on, our Black women who have been marginalized and disproportionately affected. And as we're celebrating Women's History Month, this is the closeout of March for us. And I think that we should really find ways that it can be resonated, not just in this month, but moving forward through the months ahead, because we know that different things take place in women's lives based on emotion, time, taste, smell, living arrangements, all of that. And I think our physicians should implement core values of coursework over a period of time. And podcasting, listening to podcasting, actually having someone come into their tables and really share some of the credible data that we've received over a period of time that is great for them to utilize to be able to have that refresher course, because things are changing so fast in the time and the world that we live in. And if COVID-19 hasn't showed us anything, we would be remiss to talk about that, because so many women were isolated and stuck inside of their homes and the level of death was alarming through that process. So we have to know that we have to show up because there will be another pandemic of some sort.
Mhm. Thank you so much for lifting that up, Nishi. Really appreciate that. Any thoughts, Ashley, on promoting health equity for survivors seeking HIV care?
Yeah, excuse me. Gosh, I mean, so much here, right? I think really it's so key that we're listening again to the people receiving care. And not just listening like in like, okay, I'm meeting with the doctor and they're listening to me, but like taking time to like actually gather feedback that improves our systems, like what is and isn't working. And listening to what they're saying, you know, because that feedback probably is making a huge difference in how people are able to access your services. They're able to get referrals, whatever that is. And you know, kind of along with that is like making it a norm that physicians and medical care providers in general can spend time with us. Right. So quickly, it's like this turnover process of like, okay, I've been here for 5 minutes. I got to go to the next room. That again, that sets like this, I don't know, what does that say to people when they're accessing our services that we're not able to give them the time? So how do we make that the norm in our culture that we really value you coming and spending time with me, and I'm creating space for you to share with me and us to build this relationship again. So maybe the next time or the time after that, you feel more comfortable to disclose if you've experienced intimate partner violence. Like all of those things go hand in hand in terms of how we operate in medical settings. But I think another thing, kind of like thinking, you know, we always think about, you know, what can happen on the policy level, like big P policy. And I feel like that's not exactly the answer, only because we've seen kind of the backlash that's happened over the past, you know, couple of years. And so how do we look more at little P policy and doing small things internally that can start to change the tide or change the narrative, even as simple as like, let's create our own internal organizational policies that address domestic violence. So how is it handled if a staff discloses? What if someone on staff is a perpetrator of domestic violence? What do we do there? Do we have domestic violence safety? So survivors working on staff can access supportive services or legal services or medical care if is necessary. So again, by internally making moves to address intimate partner violence, we begin to start to change the narrative in our community about intimate partner violence. So starting small.
Thank you. And starting with survivor voices, the way Nishi described. I mean, Nishi, I really want to give you the last word here before we wrap. As a survivor on this panel, thank you so much for bringing your story and your experience to this. Anything else you want to share with our audience about improving health systems' response to HIV care for survivors?
Thank you so much for having me. I want to give it up to Ashley because she is the light bright. And I want to say thank you to all of the panelists. But my last closing statement is removing the bandages, removing the obstacles, removing the stigma, and rising the empowerment for women to thrive and know that being a victim, becoming to a survivor portion is not easy. It takes years, months, weeks, days, and seconds and hours to get to this point. Mm-hmm. What I look like today, I've not always looked like. I've been through some things. And if there is a woman that is listening today and you need to step into a safe space today, do just what we shown today here on this webinar today for you all. Utilize this to impact your lives, to know that people are out here to care for you and to love on you and to strengthen you from the top of your head to the sole of your feet. We are not here to judge, and you have capacity here that will walk with you, and talk with you. Use the resources, use the links. And ladies and gentlemen, behind the voice of me as Nishi speaks, we are a true creed of blossoming women forward. And as we close out this Women's Month, take heed to the signs, the songs, the text messages, the mute buttons. And if it's someone that you haven't talked to in a while that may be in isolation mode, reach out to her and tell her that you love her and check in on the strongest person.
Thank you so much. I invite everyone to take a deep breath, receive Nishi's wisdom, and take a few seconds and think about if you have any questions for us.
Wanted to say we do have one question, Surabhi, that we got. This person asked, to get your magic wand wishes, what can healthcare staff do to advocate for those structural changes like guaranteed income and safe and affordable housing? So what can healthcare staff do to advocate for structural changes you all mentioned?
Well, Ashley, I'll turn it over to you because you just mentioned a little bit of that. And I am not sure if your team is willing to collab with the young woman who is mentioning the information, but I'll go ahead and let you take it.
Sure. Yeah. So, I mean, housing is like one of the most challenging things for people to have to navigate, for survivors to have to navigate, for a variety of reasons, right? Because housing stock is low, rent is high, wait lists for, housing, permanent supportive housing, Section 8, whatever you want to call it, are long. So how do we prioritize survivors too? I will put a plug for our housing team at NNEDV that is incredibly knowledgeable on all of the ins and outs of housing. So if you are interested in working with them, please reach out to me. I'm more than happy to connect you. But I think just starting with those connections to folks in the housing field. So maybe the housing authority isn't someone you've worked with, but being able to start that connection can open doors. I feel like most communities, a lot of communities that I've worked with, maybe they don't have housing choice vouchers, but they have the tenant or the project-based voucher units available. So maybe you don't want it a project-based, you'd rather have, the choice of living wherever, but it's at least a start. So being able to build those relationships and be connected in those spaces. And obviously this is where domestic violence programs come in as well. If you're not a DV program, being connected with them, a lot of them have access to transitional housing, rapid rehousing funds. A lot of them operate their own permanent supportive housing units as well. So those are really good organizational items to tap into. On top of that is a lot of, every state has access to HOPWA funds, or housing opportunities for people with AIDS, funds out of the Department of Housing and Urban Development. So this provides housing to people that are living with HIV. So how it's distributed across your state to be determined. It's very different everywhere, but seeing who's operating the HOPWA housing in your community or state is also another place to kind of tap into. I know of a handful of domestic violence programs that are in partnership with the HOPWA providers in their communities. So this is another place they've been able to open the door for housing to survivors that are living with HIV. And it's, just one more way to help people get into support to housing, and again, be able to remain in care with that housing. So there's different kind of things. Please reach out. I would love to chat more and be able to connect you with our housing team, who's, way more knowledgeable about these things than I am, even though I've spent years doing housing. Debbie Fox is like of all housing. So
I want to bring your attention, Ashley, to a question that Nishi answered in text, but you might have a thought about also. The question from, I think it was Blue, who said, what do you think could be an excellent way for DV coalitions to get started to offer some programming for survivors living with HIV? We do not have any programs, so I'm researching the best way to start, acknowledging the need for support. I thought maybe you could say a word about coalitions. It's a little different than health centers and programs.
Yeah, sure. Please feel free to reach out to us. You know, I know it's a different kind of setup if you're as a coalition versus being a local program offering services. So more than happy to be of support. We have done a training of trainers for coalitions. So if you're interested in going through that path, we're more than happy to engage with you and figure out what that could look like. You know, I think it's so important for coalitions to be a leader in this in their state. So kind of to encourage local programs to also buy into the need for this intersection. So just doing simple things as creating resources or hosting a webinar, you know, they're not huge things, but they can speak volumes to the fact that this is a necessary topic to be focusing on, right? So I would be more than happy to talk with you, and we can kind of strategize around what you've currently done, what maybe is being done in I believe you said Iowa, and how we can make all of that work together so that it's a, you know, a productive and successful push to really incorporate this intersection to the work.
I also want to make a little plug for an early episode of Expanding the Continuum, where Ashley and her colleagues speak extensively about Positively Safe and what you can learn from them. So I encourage you to check that out as well. Any other questions? Yes, Jacqueline, legislative advocacy is an incredible opportunity for anyone, advocates, healthcare workers, community members, survivors, to have their voice heard.
So Ruby, I think we have one more question before we kind of move to the resources by Erin.
So this question comes from Erin. Thank you. Since transgender people are more likely to experience IPV, and especially trans women have higher rates of HIV than the general population, I'm wondering if you can identify any resources from what was shared or any others that haven't been shared that are either specific to this population or that you know for certain are trans inclusive. Anyone want to take that? I definitely.
I would say the one organization that comes to mind like immediately is Forge. I believe they're based out of Wisconsin, but they're a really great organization that specifically addresses IPV among trans individuals. So they have all sorts of things, and NEDB has worked with them on a number of you know, webinars and other projects. So I would start there. I'm sure I have a list of other ones that I could pull out, and I'm happy to send them to you, so you guys can include it in the follow-up.
That sounds good.
And Ashley, I also think Sage has a little piece available in their organization too as well.
Excellent. There are also organizations like in the Northeast, like Fenway, and in Los Angeles, the LGBT Center, that have been building resources and programs specifically looking at not only trans, but lesbian, gay, bisexual, trans, and other, etc. That where they're looking at, you know, resources to look at this intersection, sometimes relating with IPV and sometimes relating to HIV, but not always. But there are important corollaries, so you could expand from what they have developed as well. I feel like there was another group in the Pacific Northwest that I'm blanking on right now, but maybe we'll put it together and we'll share the resources with you for sure. And these safety cards that we developed, I don't know if you can get a good look at them. We've really tried to build them to be trans inclusive and gender expansive in both the visuals and the text, so that providers can use these with any patient and have it be received with familiarity. So hopefully, and we also have specific safety cards for trans communities and for LGB communities that are a Northwest network. Thank you, Jacqueline. I knew it was a Pacific Northwest. But yeah, so there are many safety cards, well, a few safety cards that are specifically trans inclusive, and some more that we are trying to kind of use more gender expansive language. Thank you. Kate added some of the links to those cards in the chat. Okay, I think I'm going to pass it back to Megha, who has a couple of slides to wrap up our program today. Thank you so much for participating and for engaging with us.
Thank you, Surabhi. Again, thank you so much, Nishi, Ashley, and Dr. Spencer. Again, really appreciate and grateful for your expertise and your knowledge. I'm gonna share my screen to kind of just go over some of the resources that we have. Like Surabhi mentioned, we do have safety cards, a few safety cards that you can order from our store. I think Kate's going to be sharing the link. I know they did earlier, and they were also going to be sending this in the email afterwards. So we have the sex, pleasure, and choice safety card, which again is specific to sexual sex and reproductive coercion, sexual health. We have the health, healing, and relationship that is very specific to HIV care. And then we have other safety cards for the LGBTQ and also trans community. Again, safety card has a lot of resources, including some things that you can do to check in with survivors, how you can talk to them, some resources about where they can reach out to and contact. So again, a very great tool that you can really use and share it with people at your health center. Some of the additional resources are here. I know Surabhi kind of mentioned the cues earlier. We have a cues infographic that you can kind of look at as well and use it in your programs. We also have a QA/QI tool, which is quality assurance and quality improvement tool that you can use specifically in health centers to really provide health centers to assess quality of their care and intervention related to IPV and human trafficking, exploitation. We also have a MOU, and that is to just really provide a model that contains best practices for building and sustaining health center and domestic violence partnership. And then we also have a protocol that healthcare staff can really use as a support resource. And then this website, IPV Health Partners, I think is a really great website where you can find a ton of resources. There's a PDF toolkit where you can really learn how to partner with DV organization, partner with health centers, preparing for intervention, training folks, evaluation. So really great resource as well. And then I know this is a podcast that Surabhi kind of talked about earlier, but this podcast is a great resource for anyone who wants to really learn more about exploring the intersection of HIV and intimate partner violence. I know Ashley is also involved. And there's, I think, like Surabhi said, a new episode coming out soon. So we'll be sharing the link to that as well. And then lastly, we do have 2 learning collaboratives coming up. So the first one is kind of focusing more on care and safety for patient experiencing IPV and looking at the intersection of behavioral and mental health. And we're going to be actually collaborating with National Domestic Violence Trauma Mental Health Organization. I always forget their full name. And then that deadline is April 21st. And Learning Collaborative is a 4-session where we have a cohort, we bring in speakers, and it is more kind of more in depth. We look at the topics more in depth and just really trying to make sure that we're providing everyone with resources and tools around that. And then we have another one also coming up, structural competency learning group for healthcare staff, and that is happening on the deadline for that is April 5th, and we'll be sharing the registration link for that as well. And I think that one we're collaborating with health outreach partners with the Learning Collaborative. So some really cool learning opportunities for you all to participate in if you're interested. And lastly, we do have an evaluation link. So if you could, we're gonna put that in the chat. If you could fill out the evaluation link, that would be really great. We really use that to make sure that our webinars and learning collaboratives and everything that we do is successful and what we can do to improve. So please feel free to do the evaluation. And then if you are interested, you can also sign up for our Catalyst for Change, which is a monthly newsletter that we send out. And you can sign up for that at the bottom of our website, Health Partners and IPV and Exploitation. And with that, again, thank you so much, everyone, for being here. Thank you to all of our panelists, our interpreters, ASL interpreters, as well as Andrea and Annabelle. Again, Kate, thank you so much, everyone, again, for being here. And we will see you all later.